Hi there, you're listening to the American College of Cardiology's CardiaCast. Today, the title of our podcast is The Evolving Role of PCSK9 Inhibitors in LDL-C Management. Today's discussion is part of a series of educational activities that includes an accredited tutorial, or MedX, that was released on February 26th. Follow MedIQ and ACC on X for more information. This series is brought to you by the American College of Cardiology Foundation and MedIQ and is supported by an educational grant from Merck. My name is Dr. Michael Blaha. I'm at the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease, and it is my great pleasure to have my friend and colleague on the line with us as well for her expertise. This is Dr. Ann Marie Navar from UT Southwestern Medical Center. So Ann Marie, so glad to have you on the podcast.
Mike, it's always fun to talk to you about our favorite subject, which is prevention.
Yes, prevention, even better, lipids, right?
Indeed.
All right, so we're going to break into our discussion today, really focusing on a little bit about our new guidelines, of course about LDL management, where the theme is now lower for longer. And we're going to zero in on PCSK9 inhibitors, where of course we have new options and new options on the horizon that I think will revolutionize the way we think about particularly oral chronic therapy for LDL management. But before we get there, let's go right into the new 2026 ACC AHA Dyslipidemia guidelines. I know that's a mouthful, but it's a big deal in our field, right, Ann Marie, where we have new guidelines that really, once again, the theme is lower for longer. So what did you think of these new guidelines? Well, you were, of course, part of them, but what do you think?
Well, I was really pleased that we were able to get what I think is a lot of really practical advice on how to treat lipids. And perhaps the most important thing we did is bring back lipid goals.
Yeah.
And I think that's important because we're clinicians. We like to sort of overachieve. And so giving people a number is really helpful. It's also helpful for the patients because oftentimes to get to the LDL goals, we need multiple therapies. But if we give our patients a target that this is where we need to get or lower, it really helps facilitate initiation and then intensification of therapy as we need it.
Yeah, completely. I agree. Actually, those two words are part of the buzz, I think, from the new guidelines, both initiation and intensification. And I think it could also reduce the variability in care a little bit, right? If we all have a number that we're shooting for, instead of one clinic chooses one set of goals and one clinic chooses another, hopefully we'll all adhere to our new targets or goals in the new guidelines. And of course, part of that involves lower LDL goals for more patients. So Ann Marie, I guess let's talk about maybe secondary prevention first. So what does it say? What do the guidelines say about so-called high-risk and very high-risk patients?
Well, I'll first sort of simplify because there's over 100 pages of the guidelines and they can feel a little bit intimidating. But I try to keep it simple. There's the lowest risk patients. Their goal is an LDL of 100. Then higher risk goal LDL is 70. Those are people with diabetes and multiple risk factors or some amount of atherosclerosis on a CAC scan, for example. And then the highest risk patients are those in secondary prevention. And for the majority of those patients, we recommend an LDL goal less than 55. I think we have to put a little asterisk on that, and that asterisk is actually perhaps best explained in the accompanying editorial led by Roger Blumenthal and Pam Morris, our chair and co-chair of the guidelines. Because when we wrote these guidelines, we were using data before the Vesalius trial. And so what we had to guide secondary prevention were really clinical trials that targeted patients with secondary prevention and additional high-risk features. And so if people have multiple events, if they have polyvascular disease, if they have ASCVD and other risk factors, they're not hard to get. Things like age over 65, hypertension, and LDL over 100. Those are individuals that we recommended the more intensive goal of less than 55 milligrams per deciliter. For the rest of secondary prevention, those are people with maybe athero who've had a stent but not multiple events, or a prior MI without other risk factors. The 55 was considered an optional goal, recognizing the biology that suggests that lower is better. We had yet to see any heterogeneity in the benefit of lower is better in secondary prevention, but we just didn't have that same level of data available to us at the time those guidelines were written. That said, after our evidence review was complete and these guidelines were sort of out for vote, we had the Vesalius study, and I think that's really going to be useful to inform clinicians, and I think actually help simplify how to implement this as clinicians, because that optional goal of less than 55 is probably the better goal for everybody in secondary prevention at this point.
Yeah, I agree. And there's some interesting things to talk about there, right? One would be, of course, in the guidelines, it even mentions in the primary prevention space when the calcium score is really high, let's say about 1,000, that you're also going to shoot for less than 55, which is this overlap between high-risk primary prevention and secondary prevention. And then, of course, like you mentioned, these secondary prevention patients who we wouldn't have considered to be very high risk before. So let's get right into the Vesalius trial, as you mentioned, because this covers directly these concepts that you mentioned. So maybe you want to remind us real quick what the Vesalius trial was and what drug it was testing?
Yes, so prior to Vesalius, we had 2 large cardiovascular outcomes trials for PCSK9 monoclonal antibodies. That's the Fourier trial for evolocumab and the Odyssey trial for alirocumab. Those included patients with either prior ASCVD or a recent acute coronary syndrome, right, and randomized them to PCSK9 versus placebo. Almost everybody was on a background of statin therapy, achieved LDL levels down into the 30s or even below, and found a reduction in events. So that's where we started. But then the question becomes, well, what about people who have athero but maybe haven't had an actual thrombotic event? And we're starting to think, instead of this idea of primary versus secondary, have you ever had a plaque rupture or not? Now we're thinking, well, we should maybe think about this as athero on a spectrum. So the Vesalius trial now took people who hadn't had a prior heart attack or stroke, but had athero on imaging, a CAC score of 100 or above, or a prior angiogram showing coronary disease without an event, or people with high-risk diabetes, and randomized again to evolocumab versus placebo on a background of lipid-lowering therapy, similar to the other outcomes trials for MABs, achieved very low on-treatment LDL cholesterol, getting again down into the 30s, and found a really impressive reduction in both MACE-3 and MACE-4 when we gave people evolocumab, a 25% relative risk reduction compared with placebo, which is just really striking. And although the ordering didn't quite shake out to be technically statistically significant, there was a reduction in mortality too, which just kind of, again, reinforces that there probably isn't something magical about whether or not you've ruptured a plaque. We should be thinking about lower is better in patients who have a lot of atherosclerosis, and that includes people with imaging evidence of athero or high-risk diabetes where we know the prevalence of atherosclerosis is incredibly high.
So that's such a great point, that it's really shifting the model, right, like you said, away from strictly primary and secondary prevention to thinking about athero burden on a continuum, and more patients, at least with atherosclerosis, needing lower LDL for longer in these new guidelines, including patients with high calcium scores, diabetes, as you mentioned, and these other patients we always wanted to treat more aggressively but didn't quite fit in to Odyssey and Fourier inclusion criteria. So I think what your point there really drives home is kind of aggressive LDL lowering, and really that takes us to PCSK9 inhibitors. Of course, we still have the option of using a drug like ezetimibe in patients maybe that are near their LDL goal, but there'll be a lot of patients that need a stronger drug with more clinical trial evidence to get down to those low LDL goals. And for many patients, that is a PCSK9 inhibitor. So, Ann Marie, what are the options right now out there for PCSK9 inhibitors? And we'll talk about the horizon, but what do we have available now?
So, right now, we've got 2 monoclonal antibodies, evolocumab and alirocumab. Those bind to PCSK9 in the bloodstream. When they do that, it prevents PCSK9 from binding to the LDL receptor. When it does that, if PCSK9 binds the LDL receptor, then when that receptor is pulled into the hepatocyte, it's targeted for lysosomal degradation. In the absence of PCSK9, that LDL receptor is recycled back up to the cell surface where it can continue to pull LDL out of the bloodstream. So these really mechanistically complement what statins do. Statins increase the production of LDL receptors. PCSK9 inhibitors let them live longer. The other option we have currently available is inclisiran, which is an siRNA. What that does is it prevents the synthesis of PCSK9 in the hepatocytes. The monoclonal antibodies lower LDL by 60 to 65%, depending on what study you're looking at. The siRNAs are about 55 to 60%, so slightly less, probably because we have a little bit of PCSK9 made by tissues outside of the liver. But both really impressive reductions in LDL cholesterol. As you mentioned, even on a statin, where you get a 50% reduction in LDL cholesterol on average with a high-intensity statin, if you're starting at over 110 for the LDL, you're probably going to need more than just a statin to get to that less than 55 goal. And so the hope is, in the new guidelines, by giving these specific targets, we're going to see more patients ready and sort of willing to start with the statin, but then advance on to using additional non-statins to try to get down to that safe green zone of not 55 on the nose, really less than 55.
Yeah, less than 55, that's right. So yeah, there's more flexibility to consider going to a PCSK9 inhibitor as your next therapy rather than straight through as ezetimibe, although that's always a great option too. So it's really exciting to think about getting perhaps more patients on PCSK9 inhibitors. And you mentioned some good things about these therapies, that you can take them every 2 weeks, or with the siRNA, maybe you can take them as infrequently as every 6 months with inclisiran. But of course, there's new PCSK9 inhibitors on the horizon too. In fact, we have a newly approved PCSK9 inhibitor called lerodalcibep liga, which is approved this year, which is a small fusion protein that works a little bit differently, right? And you can take this every month and store it at room temperature for a longer period of time. I don't think it's available for use yet, but it gives us one more drug to use in the injectable space for PCSK9. So, Ann Marie, what do you think about, the Liberate-HR study and then this new drug, lerodalcibep liga?
Yeah, I'm generally excited for more options for our patients. I hope that more options helps also increase access. So, lerodalcibep is a once-a-month injection, as you mentioned. It's subcutaneous. It was very well tolerated and led to a pretty substantial magnitude LDL reduction when administered monthly. We're again looking around 60% reduction, which really isn't surprising. Even though evolocumab and alirocumab are monoclonal antibodies, this as a small fusion protein does the same thing in the sense that it binds to PCSK9 in the blood and prevents it from doing its job.
Yeah, that's what we're seeing. Yeah, this class gives 50 to 60% or more LDL lowering pretty consistently across a lot of different options. And of course, we mentioned we have several injectable options now, including the siRNA drug inclisiran. But even perhaps more exciting on the horizon, in the near horizon, is bringing oral drugs, oral PCSK9 inhibitors to the market that might open up more and more patients to taking this class. But before we go there, what do you think are some of the pros and cons of the existing PCSK9 inhibitors that we have? In other words, what is the need for more drugs in this class?
Well, you mentioned the patients, and we certainly do have patients who just don't want to be on an injection. Some that are really needle phobic. In general, when I get patients to do the very first one, these auto injectors are really easy to use. There's not a lot of pain. It's a little pinch, and the injection site reactions are usually very mild and go away quickly. But there are people who don't want an injection, and I think also as we start to expand the aperture of patients who need to get to less than 55, there's something psychologically that feels like a much bigger deal with a shot than with a pill.
Yeah, I agree.
If we're talking to people with primary prevention, they've never had an event, they're already taking their statin every day, and we're saying now you have to add an injection. It feels a lot different, I think, to patients than maybe adding a pill. The other challenge is actually not the patients, but the docs. And when we look in the utilization patterns across the United States, at least a third, if not more, cardiologists have never prescribed a monoclonal antibody injectable PCSK9 inhibitor. Mm-hmm. The vast majority of primary care doctors haven't. Now, I sit in a prevention clinic like you do. We have 40 minutes with a new patient, and I can spend a lot of that time explaining everything. I show them how to use the drug with the demo pen.
Right.
But I think in primary care, it actually does make a difference in terms of the time it takes to prescribe and the sort of clinical inertia if you have a pill versus an injection. And so what I'm really optimistic for, hopeful for, is that the availability of a pill or pills, and we can talk about what's on the horizon, will allow more primary care physicians and advanced practice providers to prescribe non-statins as well. Because I think that's really the only way we're going to move the needle as a population, is to get more of our generalists comfortable prescribing non-statins to our patients who need to get to goal.
Yeah, I completely agree. As you know, I spend a lot of time, as you do too, in the primary prevention space. And that's where we're going to make the biggest dent in this disease is, of course, starting earlier. Starting patients who haven't had events might be at risk. And we know treating earlier leads to probably more lifetime benefit. At least we certainly can infer that from lots of different observational and genetic studies. And I agree with you that patients, when you start on an injectable, hey, they actually find it pretty easy to do the injection, but they think of it as a pretty big deal. Oh, I'm taking a biologic drug or I'm taking an injection. Maybe they're accustomed to it in the GLP-1 era, but still, it seems like a big deal. And when we talk about taking this for a lifetime, there's some limitations, or at least a conversation that needs to be had. So let's talk about where we're headed with oral PCSK9. And you're the perfect person to talk about enlicitide, having been a part or leading some of the clinical trial program. But enlicitide is our first oral PCSK9 that's closest to reaching the marketplace. So can you tell us a little bit about the drug, mechanism of action, and then some of the trial data that you led?
Yeah, so this is a really cool drug because it was actually thought for a bit that this was an untargetable target with an oral, that you just couldn't get a pill into somebody that would then be able to inhibit PCSK9.
Right.
And so what the scientists who developed this drug were able to figure out is they created a macrocyclic peptide that does what a monoclonal does. It binds to PCSK9 in the bloodstream and prevents it from doing anything to the LDL receptor. But they found a common food additive called sodium caprate, very safe, that when added to the pill allowed enhanced absorption. And so if you take it first thing in the morning, wait 30 minutes before you eat or drink anything, that you could get enough blood levels of enlicitide to have a therapeutic effect. So in the clinical trial, we have several clinical trials now of enlicitide. The two largest is the Coral Reef Lipids trial and the Coral Reef HeFH trial. The latter were people with heterozygous FH, and the former were people either with ASCVD or at risk for ASCVD who had LDL levels of over 55 or 70, depending on the indication. Mm-hmm. Almost everybody was on background statin therapy. A large proportion were on ezetimibe, and compared with placebo, we saw about a 60% reduction in LDL cholesterol in both. And when we pool the data together and look at the on-treatment population, like the patients who had stayed on drug and were still in the trial, at week 24, there was a 64% reduction in LDL cholesterol compared with placebo. So just a very, very powerful LDL lowering option in the form of a pill.
Right.
You know, the one downside is, and I was a little bit worried about it in the trial, was, you know, we did have to tell people to take it fasting. You can take your other drugs with it, so they could take their other statins and ezetimibe and things at the same time, but they had to wait 30 minutes before they had breakfast. Turns out we actually saw really remarkable adherence in the trial, mm-hmm. and almost everybody opted into the open label extension. And so what I think is that actually that fasting instructions was just a recipe to make a habit out of this. And so people sort of got used to wake up, take your drug, and have it over with, check the box, and move on. And so it was a useful lesson to me about, you know, when we prescribe orals, we need to make sure that we do something to help our patients make a habit out of it so that they stay on these drugs over the long time.
I think that's a really, really good point. Certainly any of us who've taken a medication, trying to take it consistently, realize that a habit, a schedule is needed. Right, and this is sort of like a forced schedule, or at least a commitment to taking the medication. I found, even just anecdotally, let's say using oral semaglutide in the weight loss space, that this can be quite a benefit for the patient too, who's making a commitment to taking this every day. And it's similar that you need to take it with at least 30 minutes on an empty stomach. And I found clinically, that patients are more open to it, and I found it easier to teach about this than I might have thought. So I'm optimistic about this too, but it is an important dosing limitation of this therapy.
And I'll just add two other quick things. One is there is a study going on now about whether you can maybe have like a cup of black coffee or tea. So there's ongoing work to kind of understand a little bit of the interactions. But we do know from interaction studies that you can take it with Synthroid or other drugs that have a narrow therapeutic index are safe to take with enlicitide. And the safety was equal to a placebo. We really saw no excess adverse events with enlicitide compared with placebo, which really mirrors what we see with the injectables. You know, besides injection site reactions, right, are just incredibly well tolerate it. Once somebody gets on these drugs, they really don't stop for side effects. They stop because they either lose their insurance coverage or change plans, and they have to, go through approval again.
That's a really good point. I wanted to mention that, which is, of course, as targeted therapies, they're very specific in what they're trying to accomplish. And despite this being an oral therapy with this additive that you mentioned, there's no GI side effects or no diarrhea or something that you might hypothesize, but no, that doesn't seem to be the case in the clinical trial program. We'll come back and talk about where this might fit in, but I want to talk about the other oral therapy in development, which is AZD0780 from AstraZeneca. This is a in development, unnamed kind of yet, oral PCSK9 that is similar but a little bit different. So, Ann Marie, let's talk about the similarities and the differences with this other oral PCSK9.
Yes, I think we do have a generic name for it now. It's laroprovstat.
Okay, there we go.
Lero is oral spelled backwards, which is sort of a clever little naming convention. But laroprovstat has a little bit of a different mechanism. So the other ones mostly have prevented either PCSK9 synthesis, the siRNAs, or PCSK9 binding. This actually allows PCSK9 to bind the LDL receptor. But what it does is when it becomes internalized into the hepatocyte, it prevents the lysosomal degradation of that receptor. So the end mechanism or the end result of PCSK9 doesn't happen, and the LDL receptor is able to be recycled. We have phase 2 data for this drug, which unlike enlicitide actually does not have to be taken fasting. So, for people maybe with erratic schedules or, can't live without their first latte in the morning, maybe this will be a better option. And the data for laroprovstat, depending on the dose given, show up to about a 51% reduction in LDL cholesterol with the highest dose of 30 milligrams once a day.
So this is amazing. So I think what we're leading to is, right, with oral drug 1 and oral drug 2, oral drug statin, oral drug potentially PCSK9, talking about getting cumulative LDL reductions like 80%. I mean, we're talking about to get most patients to goal. And it sounds a lot simpler, right? Think of oral drug 1, oral drug 2. That sounds a little simpler than talking about injectables and monoclonal antibodies and things. So let's just talk a little bit about where you think we're headed. I'll just make the case now that I think that primary prevention might be one of the biggest areas that this is going to impact, because we talked about primary care, we talked about our general practitioners who see these patients might be more apt to use these. But what do you think? Where are we going to see the biggest impact of oral PCSK9?
Well, obviously it's going to depend, as most of our new therapies do, on things like cost and access.
Of course.
Although, we have seen some signs that this may be a space where there's additional innovation happening. I think part of the terms for the FDA's review of enlicitide on a shortened timeline that they were able to get has some terms around pricing and access. Nothing's that's publicly disclosed, but if these drugs are well priced and if we don't have our hands tied by the payers, I think this could revolutionize how we treat lipids and actually perhaps even open up more prescribing of the injectables as well, right? It's almost like if you're a physician and all you've had in your toolkit is a statin and ezetimibe, now you start prescribing an oral PCSK9, you get comfortable with that.
Right.
You may be more willing to also say, well, let me add to my armamentarium these other drugs that I've sort of been ignoring for a while. And really the dream, in my opinion, is a fixed dose combination of a statin with enlicitide or a statin with laroprovstat, where instead of saying, here's another pill, which is just always hard, to say, let me switch one pill to a different one. Sort of like what we do when we go for an ARB to an ARNI in patients with heart failure. I'm going to take away one prescription and replace it with this other one that's a combination of two things. That, I think, is going to really help overcome patient reluctance to additional therapies and really could be transformative in the acceptability of non-statin therapies for patients as well.
I tend to agree with you. I think that's going to be a really big deal. I hope we get those fixed dose combinations, at least in short order. And I actually agree with what you said strongly, which is it's not just going to be, I'm talking about the oral PCSK9, a replacement. Well, we're going to use less monoclonals, we're going to use more orals. I think it's going to open up the practice to more new patients. It's going to bring more new patients into the fold rather than just an alternative for existing therapies. And like you said, there should be hopefully positive impact on the entire class of PCSK9 inhibitors. But I think it's going to bring new people in, and then we can just decide, well, what's the right drug for the right patient, right? Is this someone who maybe an oral therapy is right, or is this someone where an injectable is right, or is this someone who really prefers to be on an every 6-month injection? All of those are acceptable because the LDL reduction is outstanding, at least above 50% for all of them.
We're just going to have to see a lot of paradigm shift, though, around lipid management.
Yeah.
Even starting with something as simple as LDL cholesterol testing, even in patients with ASCVD, when we look back, almost half often in some studies have not had a lipid panel in the last year. It's really reinforcing for the patients when they see their LDL go from 100 to 50. Mm-hmm. Oh man, it's working.
Yeah, we've done something.
It's really unreasonable for us to expect patients to take a drug every day if we're not giving them any feedback that it's doing something. And so we've got to do a better job at measuring lipids in the first place and those at risk, starting the therapy, but then following it up to make sure that they're getting to goal, and then, also identifying patients who maybe have dropped off on their adherence a little bit that need some reinforcement. We've got to get more people using these drugs, and we have to get our health system better at thinking about lipids as something that we have to make sure that we're checking regularly on all of our patients with or at risk for CVD.
Because we can do it. We can get our patients to go. We have the tools now. It's just a matter of doing it. Like you said, checking the LDL, of course, checking your LP(a) too. Not our topic today, but check that as well. Let's finish with one discussion point, briefly. So, okay, you talked about a paradigm change in LDL management. Let's just talk about the future. Do you ever see a paradigm change where we might say at some point in the future, well, you know what? Maybe we'll go straight to a PCSK9, or maybe more quickly abandon, let's say, the effort to get a patient with statin intolerance on that statin and go straight to a PCSK9 if we have potent oral therapies that are well tolerated in the future. Is there going to be a shakeup in the paradigm of LDL management?
Well, realistically, I think that the first shakeup is going to be starting combination therapy earlier. If you have somebody whose LDL cholesterol is 130 and they need to get to 55, why are we waiting to start more than one drug? We don't do it with hypertension anymore. We've got guidelines that recommend combo therapy up front. I think that the first step for that paradigm shift is going to be, instead of gating it one at a time, starting statin plus at the beginning. Mm-hmm. Now, It's not unreasonable. Imagine a future where if everything we know around the biology of lipid lowering is it's the delta LDL, if we know mechanistically that both mechanisms, either HMG-CoA reductase or PCSK9, both lower events, why do we have to start with a statin? I think right now, with price, just the reality of our healthcare system, that of course we're starting with a statin. But if I think a lot of patients, given the choice, you want a statin, which for better or for worse has decades of experience, but also decades of misinformation, and people have a lot of worries about it. There's also a real but small increased diabetes risk with statins, that patients may really prefer to have an option for the first line that isn't a statin. And I do think that the sort of statin first requirement that we have now does prevent a lot of people from getting onto the lipid lowering pathway in the first place. So my ultimate dream would be to have the ability to have multiple options, not just as the add-on, which is what we have now, but multiple options to start. Mm-hmm. I've got multiple tools: ezetimibe, statin, bempedoic acid, PCSK9. They're all available and accessible. What works for you as the patient? We're going to need a lot of change in the cost and the accessibility, but I don't think that scientifically it's unreasonable future paradigm.
Well, very intriguing. And certainly the theme today is more options is better, and get our patients lower for longer is the new mantra. So thank you all out there for joining us today. And as I mentioned at the outset, this activity is part of an educational series provided by the American College of Cardiology Foundation and MedIQ, and supported by an educational grant from Merck. So follow MedIQ CME and ACC In Touch on X to review the previous activities in this series. So Ann Marie, thank you so much for joining us today. You're incredible. What a great conversation.
Thanks, Mike. Always have fun talking with you about this.
Yes, and my name is Dr. Michael Blaha, and thank you so much for joining us today. Hope you enjoyed this activity.